Hello everybody, my name is Jill Hawksworth and as the lead for the Royal Family Society West Yorkshire Steering Group, I'd like to welcome you wherever you are in the country to this popular webinar about how to get better at involving patients in decisions about their care. I'd like to thank all the speakers, both the patients, Andrew and Graham, and the pharmacists, the very busy pharmacists, Angela, Justine, Sandra, Heather and Julie, for all their hard work in developing this event, and for the RPS staff, Anna-Marie, Rachel, Amandeep and Heidi for helping to make sure it happens. I'd like to pay a very special tribute to the initiative of Julie Sauter, a member of the RPS West Yorkshire Steering Group, who has led on this project. And I'm now going to hand over to Julie. Thank you, Julie.
Thanks, Jill, and thank you for that. But thank you very much, all of you, for joining us tonight. And thank you, Jill, for your introduction there. This whole subject around consultation skills and helping patients to make better decisions about their care through a partnership approach is one that's been very dear to my heart for a long time. And I've been involved in teaching undergraduates and postgraduates about consultation skills, as well as my research being within that area as well, about patient information needs. And with that in mind, we developed a very similar event, the one that we're running tonight for all of you, as a face-to-face event in West Yorkshire some time ago now. It was at the end of 2019. And we're hoping that the event tonight will be as close to being as participatory as that was, by helping you to participate through the chat box. And you'll have seen instructions in the first slide earlier on about how to post your questions, your comments in the chat box. And we would really love all of you. We've got a big audience and it would be great to get your questions, your ideas and comments throughout the presentation. So please do that. This event itself was developed in collaboration with patients, and the event tonight will be presented as a joint presentation with patients. So I'm very excited about that as well. So I'm going to take you through the programme just so you know what to expect and how you can get involved in all of this. We're going to start off with one of our patient representatives, Graham Presswidge, giving us an overview of what the problem is from the patient perspective. Now, Graham is both a patient and a patient representative, and he makes sure that the patient's voice is heard in many projects and initiatives. So he works across various different organisations and is a bit of a legend in his own lifetime. We're then going to move on to a conversation about the lived experience, and the conversation will be between Andrew Taylor and Sandra Martin. Andrew is a patient and he wrote the article that we recommended you read prior to this event. And if you've not had an opportunity to do that already, please do. It's a very powerful piece. So he's going to be in conversation with Sandra Martin, who's a lecturer at University of Bradford and is a programme lead there for the postgraduate foundation programme in pharmacy practice. And Andrew and Sandra have worked together to give students an insight into the patient experience on that programme. So this will mirror that type of approach. We're going back to Graham after that, and he's going to talk to you about an initiative he led with other patients about to develop a patient's charter. And this to me was very helpful, very useful. And I think you too will find it a useful tool to use in your practice if you don't already. After Graham's presentation, there's going to be an opportunity for you to put in the chat box again your thoughts and feelings about what you've learned so far from the presentations. And then Rachel and the RPS team is going to pull that together into a word cloud, which she'll send out to you after the event. We're then going to move on to Amandeep Dol, who's the inclusion and diversity representative at the RPS, and she's going to give us a lot of practical advice about how we can include all factions of society in our consultations. Then we're going to move on to listen to some practitioners, some practice researchers as well as being practitioners, Justine, Angela and Heather, and they're going to tell you about the impact that patients have had on their research and their practice. After that, we'll have a Q&A, so I'll come back to chair that, and we'll pick up your questions from the chat box. So that's, you know, an opportunity for your voice to be heard and for us to ask you questions. And then we have the opt-in peer discussions after we've had an opportunity to think about what you can do differently. We can continue with that in the peer discussions. Okay, I would really encourage you to join those peer discussions as well. So I'm now going to ask if we can move on to looking at the learning outcomes, just as a quick reminder for you. So have a quick look at these. You've seen them before, but it's just to let you know what we're focusing on. And I'm going to hand over to Graham now to start his overview of what the problem is.
Good evening, everyone. I would like to say it's lovely to see you, but I can't. But I hope you can hear me loud and clear, and looking forward to spending a few minutes with you now and a little later. If we move on to the first slide, this is to remind me to set the scene. Imagine me as a patient setting off up my own hill of ill health, set off in all good faith, made a similar journey to a healthy hill, only I set off with the wrong grid reference to start with. My start in life wasn't that brilliant. I was in the wrong place, but I worked just as hard as everybody else did to stay healthy and managed to get myself not very healthy. And there's you helping me, wanting me to be at the other hill, up the other mountain, where health and well-being is the order of the day. They're miles apart. There's just a start point that's different, but the journey between the two involves me coming down my mountain, a long journey, across the very boggy bit in the bottom. And in the Lake District, there was always a very boggy bit in the bottom where it's a bit hard going. And then to climb up to the top of the Health and Wellbeing Mountain and join you up there. So this evening is all about helping me make, as a patient, that journey from my mountain of ill health to the mountain of health and well-being. And I hope by the end of this evening, you feel confident to get there. The problem that you face as clinicians is getting more difficult. Of older people, the over 65s, over the last 20 years, then the proportion of people taking 5 or more medicines has quadrupled. The number of people over 65 not taking any medicines has fallen from just 1 in 5 to now only 1 in 13. And approximately 65% of 65-year-olds and 80% of 85-year-olds have 2 or more chronic conditions. Add to that the unplanned hospital admissions that occur as a result, 17% of hospital admissions. The size of the problem starts to become very clear. If we think and move on to Chris Whitty, a well-known name, but in January 2020, when he talked about the rising challenge of multimorbidity, I don't think he had in mind the challenge of the following year that he actually had. The next slide, because he was pointing out that treating each disease as if it exists in isolation is not the order of the day. People have more than 1, often 2, 3 or 4 concomitant conditions, and therefore the medicine's requirements are complex and need a lot of people to be able to bring that story together in one single story. Now, this is no new issue. People have been writing about the problems with medicines for many, many years. You can go back and check out lots of stories about attempts to put this right. But one of those, next slide. But one of those stories that is always missing is the fact that medicine teaches people about the population response to a medicine, both the benefit, the therapeutic effect, and the unwanted effects of a medicine. Those two lines illustrate the average line. But as an individual, I don't sit on the average line. As an individual, I'm somewhat to the left or somewhat to the right of each line. The challenge you have as clinicians is you don't know where I am in that box. So we have the clash of me as an individual and you as a clinician with your knowledge of the average of people. And it's that coming together of those two pieces of single patient experience and the knowledge and how to find the common ground between the two. And that is the most interesting and exciting bit in terms of overcoming the problem. Next slide, please. So this is my attempt at drawing the National Health Service. People principally look after themselves. With additional changing needs, they go and seek additional care in primary care. And if everything's falling apart, we move on to secondary care. And as we get better, our urgent needs are dealt with, we start to be able to live independently again, and we go back to planned care where we look after ourselves. And in each of those circles, those yellow circles, is an opportunity for conversations and discussions about how and where to use my medicines safely and properly. Next slide, please. The challenge is for yourselves, in order to help me make sure that the 8,000, nearly 9,000 hours that I'm responsible for my own care is put to good use. You only have about 3 hours a year to help me get to the competencies and skills necessary to spend all that time on my own using my medicine properly. Next slide. So to finish this section, as a patient, what I meet is people who are working very hard to bail out the sinking ship and to get me back on track and to help me get there to the top of the health and well-being mountain. On the other hand, I also meet people as a patient who don't think there's a problem and think that everything's all right. And I'll come back later and we'll talk about how to solve that problem. Next slide. Well, thank you very much. I hope you now feel that there is a problem to be solved and you've got some grasp of what that might look like. And I'd like to pass on now to Sandra and Andrew, who've got a lot more to tell you. Thank you.
Thanks very much, Graham. Thank you. So hi everyone. So my name is Andrew Taylor and I was born with tricuspid atresia or half a heart. As a long-term patient, I've seen and dealt with all areas of care. I've been in and out of hospitals up and down the country and seen many a general practitioner. But it's pharmacy and medicines that I'm most fascinated by. Because of this, I volunteer in several studies at Bradford and Leeds University, offering my knowledge to projects and sometimes teaching undergrads. This is how Sandra and I met. Sandra, would you like to introduce yourself?
I will. Hi, thanks, Andrew. So I'm Sandra Martin. I think Julie Sout has stolen a little bit of my thunder from the introductions, but I'll just give you a little bit more detail as well. I'm a registered pharmacist, currently working as a lecturer in pharmacy practice at the University of Bradford, and I lead several of our postgraduate taught clinical pharmacy programmes. It's in my role as the lead for our primary care clinical pharmacy programmes that I work particularly with Andrew to plan and deliver some patient-centred workshops for pharmacists who are working in primary care and community pharmacy. And so that's how Andrew and I have met and have worked together. So for the purpose of this evening, Andrew and I are planning a sort of a chat show style Q&A across the Pennines. Me in sunny Yorkshire and Andrew in sunny Lancashire on the other side of the Pennines. And Andrew's going to tell us about his experiences as a patient. So Andrew, question, what's been the greatest obstacle in primary care, by which I mean general practice and community pharmacy, from your perspective?
The greatest obstacle I've encountered in my many years of dealing with pharmacy is just the lack or breakdown of communication especially between GP practices and pharmacy.
And can you give an example of times when this has caused the biggest problem for you?
Yeah, I would have to say, sadly, that the biggest issue ever caused by miscommunication is never a solo event. As you probably will all know, high-risk medicines such as warfarin that I've been taking since the age of 5 are no longer available on repeat prescriptions. It's now only available on request at the GP surgery, rightfully so, as this puts the responsibility back in the patient's hands. And every month I have to send out an email with the dosages of warfarin I'm in need of. On paper, this sounds foolproof. The patient gets exactly what they're asking for each month, safely. Unfortunately, in the real world, human error and negligence are rife. When my INR levels are too high or too low, my warfarin dose changes, and this can leave me with an excess of one particular dose. So in the email, I may ask for 1 milligram and 0.5 milligram tablets only, omitting the 3 milligrams as I may have them in backlog. This goes through to the GP and in 48 hours is sent down to pharmacy where I can then collect through fast track and head home. This is where the safety aspect of the system really fails. I can sometimes go home with 84 high-risk tablets, 28 tablets more than I'd asked for. Pharmacy can't be blamed. They followed the order of the surgery. I often wonder, if I was a vulnerable or at-risk patient and went home confused why I had so many tablets or forgetful of the change in medication and overdosed, where would the responsibility lie then?
So, Andrew, how did you try to overcome the issue about this oversupply of warfarin?
So one of the key things I've learned as a patient is that complete trust in a system and turning a blind eye to the management of your own personal health is a really good way to end up back in hospital. Whenever I pick up my prescription, I always check the bag before leaving the counter, and preferably whilst the pharmacist is still in front of me, because the moment you walk away, any medicines in that bag that you either do not need anymore or are in excess through a dosage change are as good as lost. Medicine wastage is a huge issue in pharmacy, especially on repeat prescriptions. As patients, it is our responsibility to tell the pharmacist or GP surgery if there have been any changes, because chances are they won't know. It is also our responsibility to check all our medicines are correct at the counter before we leave the pharmacy and to return any unwanted or out-of-date medicines to be destroyed. Never flush or throw away your medicines in general waste. If we can all take 3 to 5 minutes to do this at the counter just once a month, we could not only save the NHS money, but also the environment.
So, Andrew, in that case, then, what is your impression of pharmacists based on your experiences over the years?
I have seen so many different work ethics in the pharmacists that have aided me over the many years. There have been those who have wanted to do an MUR on medicines I've been taking since childhood. There's the box tickers, the computer says no. When you have a long-term condition that requires you to visit a pharmacy more times than you see your own mother, it is so nice to have a familiar face. Locums are a vital part of keeping a busy pharmacy afloat, especially those in the cities. But having to explain my condition and why I'm taking certain medicines together every other week in some cases can feel like slamming your head into a wall. One great example of the confusion and chaos a long-term patient can bring was when I was taking both warfarin at a high dose of 10 milligrams per day and subcutaneous injections of heparin. The look of sheer dread on a pharmacist's face when 2 high-risk anticoagulants popped up on the prescription was priceless. Having to explain that the heparin was for a condition that no one could spell, let alone knew what it was, made visits to a busy city pharmacy a real chore. All that being said, there are pharmacists out there that don't see a number or a checklist. They see a human with a problem that their unique skills can help make that little bit easier. I have been lucky enough to cross paths with some truly amazing pharmacists that have gone above and beyond to make each monthly visit a breeze. These pharmacists have been invaluable to my life and deserve the recognition for the hard work and dedication they show. the personability they offer through the simplest of things like remembering your name, having your tablets ready when you arrive, listening, reminding you to book a flu jab, making sure you have enough medicines to last whilst you're on holiday, making sure all your different tablets run out at the same point each month to avoid hoarding. Honestly, they sound obvious, but you would be surprised how rare it is to find a pharmacist that actively goes out of their way to make your life easier, make you feel like you're the only patient and that you know you can count on them. Because being a patient can be scary, more so if you're new to the club. Having a friendly face that you can trust in your corner can give you peace of mind and a better quality of life. And isn't that what the NHS is truly about?
And Andrew, one final question. Has the current pandemic changed the way that you use pharmacy?
Well, COVID-19 has impacted all our lives, but for patients like myself on multiple medicines, I can tell you it has been quite the eye-opener. We were living in Halifax at the start of the lockdown and had a fantastic relationship with our pharmacist. She phoned me the first week of lockdown to check on me and to sign me up for their delivery service. She didn't want my partner putting me or himself at any unnecessary risk collecting the drugs in store. We were incredibly grateful and the service was smooth and effortless. A patient's life is never that simple. Prior to lockdown, my husband had accepted a new job in sunny Manchester, and we had planned to move toward the end of March, early April. Listening to the radio one lockdown evening, less than 2 weeks before our move, a caller rang in asking for clarification on whether or not they were allowed to move house. We listened eagerly as there had been so much confusion on the do's and don'ts. It was a big fat no. We now found ourselves stuck in Halifax 2 months longer than anticipated. And to make matters worse, we had already started the process of moving, cancelling the internet, booking a moving van, and unfortunately, signing up to a new GP surgery. I rang my pharmacist the next day to explain our dilemma, and once again she came to my aid. There was still enough scripts left at the surgery to cover the next few months, so she calmed me down and reassured me that all would be fine. The flat had been packed up in boxes since February. We'd been sleeping on a mattress on the floor, just waiting for the opportunity to book moving men and end this chapter. A window appeared at the end of May, and we grabbed it with both hands. Being high risk and moving house had its comedic moments. The moving men needed to come in and out of the flat to collect the boxes, so I needed to make myself scarce. Armed with a mop, a backpack of goodies, and a blow-up bed, I hid in the cupboard under the stairs like a famous wizard, waiting for everyone to leave. I had to be left behind as it was illegal for more than 2 people to travel together at the time. It gave me time to reflect on what I was saying goodbye to, the memories we'd made, the bars and restaurants we'd enjoyed. But leaving behind a truly outstanding pharmacist was possibly the hardest part of the move. The new pharmacy in Manchester was an independent and a very short walk from our new home, which helped a lot with the pandemic. As with any new move, it took a few weeks to get my prescription right. However, the pandemic hindered this and it became a game of whispers. The surgery would call me and I'd arrange with them what I needed over the phone. They would send on that message to the pharmacy, who would hand over the drugs to my partner, who would in turn bring them home to me. You can probably see where this is going. Not a perfect system, too many middlemen, but at least it was only until I was settled and sorted. The surgery and the pharmacy both rely on technology to make appointments or order new scripts. This was a big change for me. I much prefer the human interaction. But with the pandemic, it has been a great help. I soon became used to going on the app when my medicines were running low. It is so fast and easy. Plus, it tells me when a GP has authorized it, so I know when to expect the prescription. It has really made for a quick and safe service. However, its one downside is I have absolutely no relationship with a pharmacist whatsoever. In these troubled times, technology has helped us to stay connected, but most importantly, it has given us a quality of life in an otherwise limited new world that we could never have imagined. Nonetheless, this automated world has also distanced the patient from managing their care and therefore any decisions that may arise. So I'd just like to thank everyone there for listening. I hope this brief snapshot of my experiences with pharmacy has given you all food for thought. If you haven't already, as Julie said, there is an article of mine in the PJ. We will provide the link in the chats, hopefully, for you guys. And I'd like to pass now, I'd like to thank Sandra as well, and I'd like to pass back to Graham now.
And I'd like to thank Andrew. Thank you for sharing your experiences, and over to Graham. Thank you.
Thank you very much, Andrew. It's always a huge pleasure and a privilege to hear of your experiences, and there's always something new in your stories and sharing those experiences, and we can all learn a lot, so thank you. I'd like to now go on just to share a couple of thoughts about the possibility of where next, building on some of the comments that Andrew's made, and hopefully give you some ideas about what you might be able to do yourselves starting 9 o'clock tomorrow morning. It's only Friday, you've still got a bit of the week left, you can do lots of things. So next slide, please. We hear a lot about patient-centered care. What does patient-centered care look like? Well, there are different views of that. This is one version, which is not dissimilar from the story I hear from many of my fellow patients about how they felt patient-centered care was being delivered. But I would like to put it to you that there is an alternative view of patient-centered care. It's about sharing a common interest with somebody else. Nothing more complicated than that. What's more, it's about sharing in a skill that we had from a very early stage in our lives. We knew how to share, we knew how to make somebody feel special, we knew how to make somebody feel wanted. And it'd be interesting for you all to reflect on how that young person feels in that picture and how their dog feels in that picture as they look out and view their same similar common interest and share it together. I'm not asking a lot, it's just something that we all knew at some point in our lives. So in order to try and put a bit of meat on those bones, I went out 3 or 4 years ago now, around various groups from around the city of Leeds, talking to people about medicines. I've already described to you the problem, but we've started talking about solutions. What is it that's getting in the way? What is it that's preventing taking our medicines? So making it such a challenge and so difficult. A simple task that we do once, twice a day. Why is that so difficult? And virtually everybody started to share their views on unresolved issues. As Andrew has elegantly described how he had to work hard to help to get his issues resolved to get a good outcome. If people remain and sit with and carry their unresolved issues, the problems continue without being sorted out. So when I went around talking to lots of people from all different walks of life, they came up with very similar themes. People need some help if they are going to contribute to their medicines. It's about the conversation, the quality, the trust, the confidence with which those conversations take place, no matter who that is with. And of course, we're all, as patients, prepared to take on some responsibilities if we have the right help and support to do that. So we came up with Me and My Medicines as a nifty little campaign to support and encourage people to ask questions. It encourages people to take some responsibility, and it encourages health professionals to help and support people to use their medicines properly. And that's what came out of that work, was the website. Next slide, please. Me and My Medicines website, which you can all go to. and the logo and the brand, which is widely and easily recognized. Now then, I just want to move on a little bit because everybody's very busy at the moment and there's not much space for doing extra. But let's go back to the NHS Constitution for a moment, the 7 principles. And on the next slide, you'll see that Me and My Medicines helps health professionals to deliver on each and every one of the 7 principles of the Constitution. In other words, Me and My Medicines helps to describe your day job as far as delivering on medicines use is concerned. Next slide, please. So if we go back to my caricature of the healthcare system, you can see that what we're talking about is a system that supports people to use their 8,000 plus hours productively and useful. And to do that, it requires each bit of the system, each yellow circle where I learn a little bit more about my medicines, to work together, to be consistent in those messages and to be concise in the content so that I remember the key things that I need to know in order to look after myself effectively. And Me and My Medicines is about enabling each of those conversations to build and grow into my understanding of how to look after myself well. Next slide, please. So the question that must be on the front of everybody's mind at the moment is, what can I do as an individual to overcome some of those barriers and help to get the medicines for my patients used well? Well, the start point is to go on to Twitter and follow at Me and My Medicines. I'm looking for a lot of followers, extra followers out of this evening. So please go on. I'll be in a great place to have a conversation about some of the things that you're thinking about in relation to medicines. Next slide. I'd also suggest that if you visit the Me and My Medicines website, you'll be able to download and get for yourself copies of the Medicines Communication Charter, the 6 bullets that help to make sure those conversations become more patient-centered, truly patient-centered, help you to put your arm around and support and encourage your patients to participate in enthusiastically the proper and safe use of their medicines. Next slide. And you'll notice at the top of those little leaflets that it has a little bit of information to put in there, who you shared it with, when you shared it, and who shared it. And that, of course, for a patient adds huge value to a piece of paper and makes it much more worthwhile. Perhaps a little more challenging in these COVID times, but nonetheless the principle of giving and sharing a little bit with somebody and adding value to that. So I'll leave you with a thought, if I may, on the next slide. That you can start by using the Medicines Communication Charter twice a day, once in the morning, once in the evening. I suggest you try them for 28 days, see how you get on, and recommend that you continually aim to improve your technique. What's more, these are very safe, so you can, if you feel so wished, you can use them PRN. And the last slide is an invitation to questions. Very pleased to hear from you. You can contact me on the email address, or even for more fun, get on to Twitter at Me and My Medicines or at Mr. G. Prestwich, and I'd love to hear from you and love to join in some conversations. Thank you very much for listening.
Thank you very much for that, Graham, and thank you for all of our speakers so far. I think you'll agree with me, there's a lot of thought-provoking experiences and ideas that you've heard there. So we're just going to pause briefly at this point to get you to think about what you have learned from that. And I want you to think about your thoughts or your feelings that you've had from listening to that. And I would like you just to put you know, words that summarize these thoughts and feelings into the chat box. And what we're going to do with these is we're going to put them into a word cloud so that you can see what everybody else is thinking and feeling about these issues, the problems that we're facing, the potential ways around these problems. So if I could ask you now all to just put the odd word, even if it's just one word, into the chat box, then Rachel will put these together for us and magically produce a word cloud that will be sent out to you tomorrow. I'd also like to say just at this point, while you're doing all that, thank you to all of you that are already putting some questions into the chat box. These are being noted, and we're really looking forward to having the opportunity to post these to the different speakers a wee bit later on. So keep them coming, and we can get these conversations going after the next couple of presentations that we've got for you. So let's see all your thoughts. Great, they're all popping up in there in the chat box. Things around empowerment and feeling inspired. Yeah, and people starting to see how valuable patient contact is, and enjoying the examples that we're sharing tonight. And we are looking forward to sharing some more of your examples and experiences in our discussion groups at the end, if you decide to stay on with us, which we would absolutely love. Okay, keep those coming in. I think it would be useful now, while those are still coming in, I think what would be good now is to introduce our next speaker, because we have got a lot to cover tonight. So I'm sure you can keep the words coming in while we introduce Amandeep. Amandeep Dol is going to take our next session, and she's going to talk about inclusive diversity and some of the cultural issues that we need to be aware of and to think about when we're building partnerships with patients, to make sure that we truly are inclusive, and that we don't leave some people out just through not thinking about it, because we all mean to do the right thing, but sometimes we just forget. So can I now hand over to Amandeep?
Brilliant, thank you, Julie. I'm just going to share my screen, and I'm going to try and hopefully that will work. There we go. And doing PowerPoint mode. So my name is Aman, and I'm the head of professional belonging here at the RPS, and we've been working on, oh, does that show? Sorry, I think my computer's being a bit funny today. I think that doesn't show the slides. I'm just gonna have to go like this, otherwise you'll see like a presenter slide. So yeah, so I've picked up the inclusion and diversity work here at the RPS. We launched our strategy early in June last year, and it's very much on profession focus, so looking at how we can make the profession more inclusive and diverse. And because what we found and what the research shows us is that if we can be an inclusive and diverse profession which creates a culture of belonging amongst itself, that in turn will ensure that we deliver safe patient care, and that we will be, you know, and will ensure that the things that we consider about each other, we'll definitely be thinking about those things when we are interacting with patients. And so that's the key thing of the strategy, is to create a culture of belonging and to make sure that no one's left behind. And that's exactly what we want to do when we're thinking about patient care. And I'll touch on that more in a bit, but it's about being intersectional and that sense of belonging. So patients should feel comfortable and open when they come to you with their problems, and know that they'll get a fair and non-judgmental service, but also that's culturally aware. So there's things from certain backgrounds that people might need to be considerate of, and they're the kind of things I just wanted to touch on today. But there are two parts to this. There is the profession piece and there is the patient piece. So we're as the RPS, we've picked up the profession piece, so we'll be working with the profession on making it more inclusive and diverse. we are in ourselves a very diverse profession. We're 43% BAME and 60% women, and also so we've got a really diverse pool to work with. But what we find is that we could actually celebrate our diversity and be a lot more inclusive in our approach, and that will in turn affect patient care. And we've seen that now really in the global pandemic. You know, we've had reports about the COVID disease infection predominantly affecting patients from BAME backgrounds, but also learning disabilities, who are 4 times more likely to die from COVID. So it's really highlighted health inequalities that have been around for ages, but there's an opportunity now to do something about that. So it's how do we engage with the public, and we're working with NHS England to help establish how we can get pharmacists who are out there in the community and the hospital engaging with patients every day to address those health inequalities. And it's not just about the medicines, but it's also that holistic approach, and picking up from some of the words that have been coming in throughout the chat box today about the empathy, the compassion, and how do we make it patient-centered. So that's the work that we've been focusing on. So why is it important? So we know that everyone deserves the same opportunity to lead a healthy life, no matter where they live or who they are, what their background is. But unfortunately, that's not happening in reality. The reality is that actually, like in England, for example, there is a 19-year gap in healthy life expectancy between most and the least affluent areas of the country. So that's really big. And then from a learning disability perspective, males have a life expectancy at birth of 66 years, and this is 14 years lower than a male in a general population. And for females, they have a female with learning disabilities has a life expectancy of 67 years, and that's 17 years lower than females in the general population. And also, so from different communities, so say if you're from the LGBTQ+ community and you identify as a trans individual, trans people face a range of barriers when accessing most mainstream health services, and often avoid accessing services at all. And also, Black women are 4 times more likely to die in pregnancy compared to white women in the UK. So there's lots of reports that there is still an issue. And as I was kind of doing some research on this, I came across different articles. Unfortunately, because I can't show my slides, I can't show you each of them, but it's all about not engaging with the patient, that failure of, you know, if a patient doesn't understand English, how do we communicate with them the importance of delivering that healthcare and the instructions they might need to take their medicines, or that they, you know, aren't able to communicate back to us of things that they need. So for example, there's a patient, you know, there was a failure to feed a disabled patient because they couldn't communicate, so they weren't dealt with. And then as the article here is actually the one that's probably most thingy, if I can pull it out, is that there's a Sri Lankan lady, and because of a language barrier, she wasn't told how to feed her child, and then her child died because they needed TPN, total parental nutrition. So there are things that are happening, and we need to make sure that we are encouraging our healthcare professionals and pharmacists to have those conversations. And as I mentioned, COVID has really highlighted that at the moment, with learning disability. Patients with learning disabilities are 6 times more likely to die from COVID, and members from the BAME community. And that's not linked to the actual disability. The reports from Public Health England have demonstrated that actually it's about the other issues. It's about the language barriers, poverty, you know, where people live, and it's how do we help address that. So the reality of the situation, and this is just a slide that I wanted to share, is that there is inequalities that exist within the system, but how can we as healthcare professionals and as pharmacists address those? And it's not all about it being the same for everybody. Everybody has different needs, and it's how do we make sure that we are recognizing individual needs and making sure that we are putting things in place to make sure that there is and equality, and then there's a liberation for all, so that, you know, everyone has access to everything that they need in a way that suits them, rather than there being barriers and blocks. So some of the things I thought would be helpful to cover, just kind of as a, you know, how can we help and what can we do? The patient-centered approach is absolutely the key thing and what we should be doing, but there's considerations that we should be thinking about, and actually probably coming outside of our own comfort zone with some of these things. You know, if they're not things that we might have come across from our own backgrounds, how do we have those conversations in a way that you don't want to alienate the person that you're speaking to, but embracing that and having that difficult conversation? So there are things that we're looking at doing and that already exist. So cultural competence and communication. So being culturally aware. So having awareness of our own cultural worldview, so our own biases and unconscious biases that we might have, because we all have them. So recognizing them and being able to be aware of them when we're actually going forward and delivering patient care. Thinking about the attitudes towards cultural difference. If there's someone in front of you that's different to you, how would we want to approach them? And so that's why I'm pleased that the words empathy and compassion were coming out in the chat box, because that's exactly what we should be doing. And having a knowledge of different cultural practices and worldview. So, you know, we have access to the internet and we can Google most things now, and it's just about being aware of what's out there and thinking about cross-cultural skills, and just thinking about how can we communicate to people. And actually, you know, depending on where you work, if you've got a community pharmacy in the middle of, say, somewhere that's quite diverse, so I'm from Leicester, so I'll just use that as an example, you know, if you're a locum pharmacist there, but you've got technicians and you've got staff that work in that pharmacy that are most likely to be from the local area, so use them and their knowledge to help in delivering that patient care. And it's also about being comfortable with the uncomfortable, you know. So if we don't, say for example, we're faced with a patient that might have a language barrier and we're not sure what to do, or a trans patient, we're not sure how to interact, it's okay that we don't know, and it's okay to say that. So I'm just going to use an example from my own personal life. So my sister is autistic and she's got severe speech impediment and learning disabilities. So it's really interesting when I take her into a pharmacy or opticians or wherever I take her, people get uncomfortable and they don't talk to her directly, they talk to me. And she's able, you know, she has a speech impediment, but she's completely aware of what's going on. And she would be more empowered if someone spoke to her about her medicine rather than me, and then me explaining it to her. So I know it can be difficult in having those conversations, but it's about just getting comfortable in that situation and just reading up about it so that you know what to do. There are no hard to reach communities. So I went to listen to a patient representative, and this was the one thing that they said that really stood out to me. We describe communities, marginalized communities, as hard to reach. They're definitely not hard to reach. We work in them, we're in the community, we're working with them and we're helping them get discharged from the hospital. You know, we need to reach out to communities and interact with them and not be shy about that. So we shouldn't be thinking that they're hard to reach. We need to be open and considerate. So not one size will fit all. So for example, if someone is from a Black, Asian, minority ethnic background, not everybody from that group will have the same experience or have the same needs. So it's just considering that, even from, like, you know, I'm from an Indian background, even from someone with from an Indian background won't have the same needs as myself. So it's just being aware of that and having that conversation with the patient about what works for them. And when we're thinking about setting up a service, consider the different groups that it will impact and invite them to have that conversation. So one of the key things that came out of the public health report was about having representation around the room when we're setting up services, policies, guidelines. The people that are going to be impacted, are they sat around the table to tell you what's going to be good for them or not, or what works? So it's about making sure that we've got that representation there, and that can apply from setting up a service in a local area to setting national guidance. but that voice and inclusion of that voice should be there. So like I already mentioned, use the staff that you've got. People work really well with, you know, with their communities, and also thinking broader. So what are the local community groups that tend to be, you know, that intend to, you could interact with, that are able to be a voice on behalf of you when you're thinking about managing long-term conditions, and you know, they might listen to someone from their own community, and it's how you work with them. Education of staff and ourselves. So there are tools out there. So if you have an NHS Net account, you can access e-learning for health, and on there's a cultural competence toolkit that you can use to educate ourselves about cultural competence. But also, you know, we've got Google and we've got access to lots of information. If there's a group about if there's a group that you'd like to know more about, you know, there will be information and charities out there that can help us understand how we can interact with them most effectively. And target different communities. You know, if we are proactive in targeting, we can address those health inequalities and be preventative rather than reactive. And sharing good practice cases. So one of the pieces of work that we're hoping to do with NHS England is sharing those good cases. If you're doing something really well, then think about, you know, how could someone else learn from that? So how do we share that good practice and networking? And that bit about communication, again, it's just thinking about what we say. So, you know, telling someone from, say, I'm just going to use, again, myself and my dad as an example. My dad's diabetic, and telling him not to eat Indian food is like telling him to chop off his right arm. So it's how do we interact, you know, with that? So instead of saying stop eating samosas, just, you know, it's eat less of them. Telling someone to not eat their traditional food is quite important, you know, and can have a big impact. So it's thinking about how we can do that in a way that works for them, but also it's going to keep them safe and make sure that they're not going to be suffering from their long-term conditions. So we just need to consider the person-centered care, which we have come across a lot, and I know we've already mentioned it, but it's how do we make sure that we involve that person in the decision to treat while we're there. Effective communication skills and not being shy. And remember, there's, you know, if they've got family members, carers, use them in those consultations and involve the person. And it's thinking about the holistic approach to that medicines optimization, especially if I think sometimes we can just go with, you know, you take it 1-3 times a day and that's it, but that might not work for the individual. So how else can we do it so that it works for them, but they're still going to get the benefit of their medication? So I've just had my 1-minute warning, so I'm just going to wrap up, but we are continuing to work on this as the RPS. So I just wanted to put an invite again out there as well, just to say, do reach out if you've got examples of good practice, or if you've got ideas of how we could improve that. And in the terms of the profession piece, we've set up an inclusion and diversity network. So it's called the Action in Belonging, Culture and Diversity Group, which we're always looking, well, we're always open for members from different backgrounds, and we meet every 2 months to discuss things such as this and other groups in more detail about how we can improve inclusion and diversity within the profession. I'll put a link in the chat so that people can join if they want to, but we need your help to help us in making this better for everybody else and for the patients. So, but I'll stop there and thank you for listening.
Big thank you to Amandeep there. Again, some very useful hints and tips for all of us. And now we're going to go over to our 3 clinicians who are also practice researchers. And we're going to start with Angela Burgeon.
Thank you, Julie. Good evening, everybody. As Julie said, my name is Angela and I'm a pharmacist who works at Leeds Teaching Hospitals. I've been qualified and worked for 20 years now. I can't believe it's been that long. And I've worked all of that time in secondary care in the main. Covered most specialties, but for probably the majority of my career, I worked within surgical services, and I love my job. It feels a real privilege every day. So For the next few minutes, I just wanted to share with you, I suppose, my journey. I've had quite an interesting couple of years, and I just wanted to share an experience that really led to me hearing the patient voice in a way that I hadn't heard before. The experience really changed my perspective and also my approach to really understanding the lived experience of patients around their medicines and delivering patient-centred care. Next slide, please. So how did I come to here? So back in April 2019, I was applying to the NIHR for funding to do a PhD fellowship, and my research interest is in and around how technology has changed medicines optimization, specifically in secondary care. So as part of the funding application process, we had to do some patient and carer involvement work to really understand the patient perspective and get their involvement in the development of the research and the research proposal. So I put an advert out. I got some 14 fabulous people who came forward, patients and carers, and I ran 2 focus groups to explore that with them. Next slide, please. And this is some of the lovely people I met during that time. And I learnt loads during those sessions and after, and I suppose in the run up to as well, on the how to and also the benefits of doing patient and care involvement work in terms of their involvement in research design and delivery, but also in service improvement, and kind of now feel it's become a core value. Why wouldn't we involve patients and carers in the design and the delivery of these services we provide? But I think what was a real surprise to me and what I wasn't expecting were the other messages that I heard and that I took away from these sessions. There was lots and lots of talk in the sessions between those involved around medicine specifically and the service that we deliver across both primary and secondary care. And what I heard during those sessions really stopped me dead in my tracks. And it was possibly the most impactful 9 hours of my 20-year career. And this wasn't just in terms of involvement in research and service design, this was actually in terms of my clinical delivery. And it really felt like, I think the only word I can describe as an awakening is probably the best way to describe it. Next slide, please. So what I was keen to do was to just share a couple, there was loads in the sessions, but just to share a couple of those stories that were real hitting moments, if you like. So the first story was words from a lady. So she was in her 70s, very glamorous, arrived in a beautiful fur coat, and there was just something not quite right. She seemed a bit shy, but anyway, as she started to talk, it began to become quite clear. So this individual said, "Over the years, I've been on many drugs and things, but this is the worst thing I've been on. I'm on steroids at the moment. My hair was long and it's now shoulder length and getting worse. I've put on 1.5 stone and I just wish I could get off the steroids. The other thing is I feel unsociable. Having lost a lot of my hair and put on a lot of weight, I just don't feel like I used to when I was with my friends and relations. I've been on them now for 6 months and I understand that I'll be on them for at least another 6 to 9 months, probably longer. So the sooner I can get off these, the better. And I seem a lot more aggressive now and I used to be really calm. And does that sound odd? I won't tell you how old I am, but I've been retired for 20 odd years now. And you know, over the years, I've been on so many different medicines for different things. And this really has been the worst thing that's affected me. And now is the time I should be making the most of it, you know, of the time I've got left." And I think hearing that account from her, and actually, you know, similar messages, I suppose, but a different experience has come from Andrew's story of being on steroids. It's, you know, hearing the real impact of side effects on patients' life really affected me and made me kind of, I heard it in a different, well, it's the first time I'd heard it actually in that way. Next slide, please. So there were lots of talk in and with the patients on side effects, and it really made me sit up and think more about this tailor my treatment to me. You know, the patient said, do I actually want those side effects in my life? You know, as this individual said, now is the time I need to be making the most of the time I've got left. And there was also a quote in and around, can you just click the animation, please, Anna-Marie? There we go. It's only when you get home from hospital that you take medicines, and that's when the side effects kick in. Then what do I do? And people feeling almost lost as to what to do next and not knowing where to turn. Next slide, please. So the second story was was from an individual about their niece. So this individual said, well, yes, the birth control pill. My niece had spinal surgery at a hospital and was on intensive care, and then went down to the orthopedic ward a few hours later and had a bag of stuff. They lost the bag of stuff that had the birth control tablets in it. So I'm just going to pause there. So at the time, I was thinking, gosh, yeah, we do lose stuff in hospitals sometimes. That's not great. And well, as a surgical pharmacist, we probably wouldn't encourage you to take the oral contraceptive pill because of the risk of DVT. And I had all this going on, and you know, is it that big a deal really? And actually, she then went on to say, now for those of you who know, if you stop taking the birth control tablets, you have a period, which you don't really want when you've had spinal surgery. It does actually affect people's quality of life and their experience. And then it hit, and I thought, this individual has made an informed decision, including considering the risks. And this was about helping her recovery and enabling her to look after herself in a dignified way. Next slide, please. So really, I think my key message from that was about really understanding the patient's lived experience and understanding what their priorities are. And I think as healthcare professionals, we fall into this way of being around delivering evidence-based medicine. I mean, nobody comes to work to do a bad job. We get really we're taught, this is it becomes our being almost. Let's, you know, it has to be do no harm, let's deliver evidence-based medicine. We protocolize care and we categorize and prioritize patients' medicines in and around our own agenda, or that's set by either national or local guidance. And I think really hearing what the patient had said about that really made me stop and think, actually, we're not quite on the money because we're missing their priorities as part of that prioritization. Next slide, please. So what did I do next? Spent a lot of time reflecting and being kind. I think that was something I had to learn to do quite quickly, was to be kind, because actually after years of training, doing all sorts of things and really believing I was on the money with the job, I realized that actually I'd not been quite set up to have the conversations that people needed. We work in a paternalistic healthcare system. There's so much in this. We could spend probably another whole session just talking about it. But basically, I think the thing I had to do next, I love this document, RPS Medicines Optimization. Reading this with that new insight changed how I saw the content. And I go to this a lot. And I now change my approach. The conversation is changing and I'm on that journey with that. And I'm not saying I have all the answers and I've got it right. It's a learning journey every day. But I think one of the things I do always start a conversation with is what matters to you most. So thank you for listening. Thank you.
Good evening, everyone. Thank you for the opportunity to be here tonight. I'm Justine Tomlinson. I'm a pharmacist working at Leeds Hospitals. I'm also currently a PhD researcher at the University of Bradford. Now, following on from Angela's reflections, I really wanted to just spend a few minutes briefly describing my experiences of involving patients in my research design, and also how it's really helped me to reflect on my practice. My area of interest is medicine safety for older people, particularly during the hospital to home transition. Now, whilst my work is supported by the National Institute for Health Research and also by a wonderful team of clinicians and supervisors, and you'll hear from Heather Smith, one of my supervisors, shortly, my work's also been supported by a group of wonderful patient advisors who really ensure that the design and the conduct of the work is underpinned by the patient perspective. Next slide, please. So, as I've mentioned, my area of interest is medicine safety for older people. Now, I've predominantly worked as a community pharmacist throughout my professional career and only recently moved to hospital practice. And whilst I've served a lot of older people within the community, these have always tended to be the ones that are fit and well. I've never particularly been into a patient's home and seen how they live, And this is actually a photo of my grandma here, obviously taken pre-COVID. My grandma's 95, and this is my grandma. This is how she is every day. She's mobile, she's fit, she's well. We have a good old laugh. She's full of banter. And, you know, you could say that I've got a particularly rosy view of older age. I personally have absolutely no idea what the challenges are for these patients. I've never been a patient. I've never been in hospital as a patient. I don't take any medicines. I don't have any long-term conditions. So really, when I first started my research journey, I knew that to make the research beneficial to the patients that I wanted to serve, I needed to get to grips with what the real experience was. Next slide, please. So similar to Angela, I held some meaningful conversations with older patients and members of the public. I found lots of people that were willing to talk to me about their post-discharge medicines management. And I was absolutely overwhelmed by their experiences. And I've just popped up a little word cloud there of what they told me. They told me that they felt that there wasn't enough time to ask questions. There was a lot of unknowns. What do I do when I get home? I feel lonely, I feel lost, I'm anxious, I'm challenged. How do I do this? Who will help me? Frustrations. And, you know, as a pharmacist, we all go to work to do a good job. We absolutely try our utmost best. And it really hurt my heart to find out that there were so many negative experiences and negative emotions around medicines. And these are kind of needless if we really think about it. So from these initial conversations, I kind of flipped my research to ensure that it captured and focused on the powerful patient voice, patient experience. This work's really helped shape my research questions away from those more quantitative process measures and scale of error to more patient experience and how we can really work together to improve it for everybody. And really, you could say that from these conversations that I've become a massive patient advocate overnight. Next slide, please. So furthermore, when I've been doing my research, I've actually been going out to patients' houses pre-COVID, obviously, and interviewing them about how they manage their medicines. And again, I've been really shocked by the absolute range of strategies that they use, and going into these people's houses and truly seeing and hearing their stories of how they manage their medicines after hospital discharge has been eye-opening for me. And actually, I feel really privileged to have been able to do this. As a pharmacist, we absolutely need to be finding out more about our patients' day-to-day lives, the context in which they perform their medicines management, and find out, as Angela said, what really matters to them. We really have to increase patient engagement to find out exactly what they're doing with their medicines once they get home. For example, do they put them out on a plate in the hours of a clock, which is what one of our patients did? Do they make these spreadsheets and checklists? Do they have little things pinned onto cupboard doors? Do they do none of it? Do they live in utter chaos? I mean, there's a wide range. And if we don't find out what they're doing, how can we appropriately advise them of the safest way to do it in the way that they're used to doing? Overall, these observations that I've done of actually being in a patient's home have allowed me to see the reality for our patients. And I really strongly believe that this invisible work that our patients are doing with their medicines is missing from within the current healthcare structure. And we really need to be finding out how patients are taking their medicines, not just what and when. And that's kind of my message really for you today, is please just think about the conversation, open a conversation and find out more about how they're managing. And I'm just about to hand you over to Heather, I think.
Thanks, Justine. That was brilliant. So my name is Heather Smith. I'm a consultant pharmacist for older people. So I work for NHS Leeds CCG, but I'm embedded in the Leeds GP Confederation. And for many years, I've been really interested in and hopefully a champion for really, truly patient-centred care. So where we work with patients to support them to make choices and decisions about the medicines that really work for them. So I'm involved with training healthcare professionals in areas such as shared decision making and encouraging healthcare professionals to really ask patients what matters to them, as Angela has mentioned in her piece. It's been a real privilege to be part of Justine's supervision team, where patients have really been at the forefront of all the aspects of her research. I've championed campaigns such as Me and My Medicines, which you've heard about tonight, and also the Better Conversations project, which is a Leeds-based initiative. So this is about working with people as partners in their care, acknowledging their strengths and assets, and working to improve their quality of life and independence.
Heather, may I just ask you to move a little bit closer to your microphone?
Yeah, can you hear me better now?
That's so much better, thank you.
Thanks. So that's all I really wanted to say about me, but I'm delighted to be supporting this event tonight and looking forward to joining the panel for questions and answers.
Thank you very much, Heather, and thank you very much, Justine, and thank you very much, Angela. It's lovely to hear those very honest and open experiences from you, and very powerful too. So now we've got an opportunity for a question and answer session with our speakers. And we've been collecting, as you've been sending them in, your questions. Hopefully I've been jotting them down as we've been going along, but please do feel free to add any more that you think of as we're going through. And we'll try and address all of these. What we can't address tonight, we will answer after this evening and post out to you. I'm sure we'll find a way to do that. So I'm going to start with some of the ones that have come in, and I'm going to direct them to particular speakers, but there may be other speakers that want to pop in and add to this. So my first question that I was going to pose to the panel is, how do we encourage patients that are reluctant to be involved in their healthcare decisions to participate in these conversations? And I think I'm going to start by maybe directing that at Andrew to get your opinion initially, and then maybe Graham as well after that.
Thanks, Julie. I had a feeling that was coming my way. It's a difficult one because there are so many different types of patients, just as there are different types of pharmacists out there with different methods. Some people do prefer ignorance is bliss when it comes to their medicine or their conditions. I think the best thing you can do is just help inform and educate in a way that they can definitely understand what it is, why it is that these medicines are so important for them to be taken. And how that could help their quality of life, and any concerns they might have. I mean, sometimes people go inwards and don't ask those questions because they're more concerned. And so you might think because they've got no questions, they're fine with it, but actually it can sometimes be the other way around. Graham, have you got anything to add to that?
Have we lost Graham?
No, you haven't lost me. I've just lost the right button. Trying to give an old fella a chance here. Yeah, if I could just totally endorse what you said, Andrew, and just to add perhaps a couple of things. I think an important start point is to try and understand somebody's goals. Where are they aiming for? Rather than have your sort of set, we're talking about your such and such treatment for whatever condition, is to step back for just a few moments and think about what is somebody really aiming for, a bit more of their sort of life's aims really, because it helps to give a context to it. And I'll never forget a lovely lady telling me about what she thought was some of the best consultations she'd been involved in. And the way she described it was lovely. She said, what I like to do is to be able to tell my story and describe what's important and what I'm wanting to achieve. And then what I like my doctor to do, in this case, but I'm sure it equally applies to their pharmacist, I'd like them to tell me their side of the story, but weave it through my story so that it feels relevant and a perfect fit for what I'm trying to do. So my story and weave through their clinical story so that it forms a mesh, a net, a sort of completeness. And I just thought that was a lovely imagery of what a good consultation looks like, is weaving stories together so they form a whole thing. So I think that's what this is about, is giving people space, listening, and then weaving the professional story back through that personal story.
Those sound like very, very wise words. Very wise words. Thank you for that, and thank you, Andrew, as well. That gives you some ideas. And for those of you in the audience now, if you yourself have any hints and tips that you would like to share, please do put those into the chat box so that we can capture those and share them with everybody else as well. So thank you for that. I'm going to move on to my next question. And one of our audience wanted to know about the experiences of our speakers regarding the benefits of person-centered decision-making on medicine's adherence. And I'm going to direct that initially, I think, to Heather, actually, you know, just to bring you in with the elderly population, particularly that you're dealing with. What have you found about the approach that you're using and how that impacts maybe on medicine's adherence?
Thanks, Julie. Can you hear me all now?
Yes, we can.
Good, thank you. Sorry about that, everyone. So for me, if you don't find out what people are really doing with their medicines and what they really want and what their beliefs and values are, what their goals are, then you're wasting your time, because you're just going to be giving them medicines that potentially they're not going to take, that they don't want to take. You're not really working with them. You're just imposing your views on them. So that's the bit that's really important to me. And, you know, people will say, perhaps we don't have time to do that. But actually, if you don't spend the time talking to people about what their needs are, what's really important to them, then you're wasting a lot more resources in the long run, particularly, you know, seeing so many medicines just stockpiled in people's houses, people's cupboards. They aren't doing anybody any good if they're sat in a cupboard. You know, and that's just without thinking about, you know, the massive waste of resource that is. So it's really about truly trying to understand the person's experience and what they want to get out from life. And, you know, I can give you loads of examples, but, you know, I've talked to people who, you know, really want to take their heart medicines, people in their 90s who want to take their statins, but conversely, you've got other people who aren't wanting to have really tight control of their blood pressure because it makes them feel awful, you know, don't want tight control of their diabetes, don't want to take the diuretics because it stops them going out and doing the things that they want to do. So it's just really finding out what's important to people.
Okay, thank you for that. Maybe Justine, have you got any particular examples from your experiences of benefits of using this kind of patient-centered approach?
I think by actively opening the conversation, you're giving the patient an opportunity to really think about and reflect on what matters most to them, and you're giving them an opportunity to be open and honest with you, because that's what we need, don't we? If people don't want to take the medicines or struggling to take certain ones, you don't want them to hide that. And I think that's the main thing. I think we need to be starting these conversations, and we're not saying that the way that, you know, if somebody puts it out on a plate like that lady, we're not saying that this is wrong. We're saying let's talk about it and let's ensure that it's as safe as possible and help you to manage that. So from everybody that I've spoken to, from everybody in the patient advocate group, they all want to have these conversations. Nobody said, I don't want to talk about it. So I think it's just making sure that we have the time and we're asking the right questions, and we're not doing this didactic, take one twice a day, take it with breakfast, don't take grapefruit juice. You know, we're doing it in a more meaningful way, and we're finding out, you know, tell me how much you know, and let's fill in the gaps and work together to ensure that this works for you.
And that matches what Graham was just talking about as well, doesn't it? Angela, I don't know if you have anything to add as the final one in that group.
Yeah, thank you, Julie. I think really just to add to what both Heather and Justine said, I think one of the big changes for me after 20 years of thinking that this was the way forward is that I think one of the things that in terms of reframing how I think is it's not just about educating or supporting to ensure that people adhere more. I think I've ended up going right back to, you know, fundamentally what is health. And when you look at I think it's the WHO constitution or definition of health, it's not just about the absence of ill health, it's about the health, wealth and general well-being of the population. And so really for me, it's all of what Heather and Justine have just said, in that it's about what matters most. How can we empower patients more, involve them more? And actually the outcome of those conversations might be that on certain days that people don't take their medicines, but if that helps them in terms of well-being and sort of just generally how they are, then to me that's just as good an outcome. And I think we get really hung up on measurable outcomes in terms of medicines taken or not taken, and that is a big part of it, but actually I think just taking a step back and a bit of a wider perspective just sometimes helps. Thanks.
Thank you for that. Thank you. As I say, if people want to add their thoughts or further questions into the chat box, please do. I'm hoping the chat box is working. I think we might have had a little glitch on it, but if we have, I'm hoping that will be fixed quickly. So the next question I'm going to direct to Heather again. So I'm giving you the heads up, Heather. One of our audience have asked, how can we engage other professionals in shared decision making about the person, not just the medicines?
Thank you for that question. So I do quite a lot of training with other healthcare professionals. So, you know, I've done training for medics, but I've also done a lot of training with community matrons in primary care, because they have a lot of patients who are really, really complex. They have a lot of older people with multimorbidity. And it's the same principles that I would teach if I was talking to pharmacy people. So it's really asking that question about what matters to you, you know, how do you want to use your medicines, what is important, and just really working with the individual to get the best out of their medicines. So yeah, it doesn't matter to me who's working with an older person and their medicines, just as long as we're all doing the same things and the right things.
Okay, thank you for that. And Andrew, this is just going to hit you out of the blue here. You were just relaxing, weren't you? I just thought, I mean, from a patient perspective,
Yeah.
have you, you know, in your long experience that you've talked to us about, have you had any examples of how we as pharmacists have helped you as a you know, your entire care by contacting other professionals and helping you liaise to bring a team together so that they're thinking about you holistically?
Yeah, one of the best examples of that, I was supposed to have my annual review, as we usually do around your birthday time, don't you? So it's like September for me. And mid-June, I went to collect my prescription and my amiodarone just wasn't there. And I was told that I needed an annual review in the middle of June, which completely threw me because the surgery had never even contacted me. They'd never said a word. So I was panicking. The pharmacist was panicking. She said to me straight away, try to ring them and see what you can do. Well, I couldn't get an appointment with them for 2 weeks. It was just ridiculous. The receptionist was the most unhelpful person. So I went back to the pharmacist and I'm saying to her, you know, what am I going to do? I can't be without my heart medication. And especially something like amiodarone. The last thing I want is to go back into atrial fibrillation and end up back in hospital. So she picks up the phone and she rings the surgery, and within 10 minutes she's managed to get me a next day appointment at the GP surgery, to get the script, to get it down to the pharmacy and get me the medication that I needed before the tablets ran out, the few that I had left ran out. I don't know what I would have done that day if pharmacy wasn't as accessible as it is. If community pharmacy was anything like a GP practice and I had to wait 2 weeks for them, I don't think we'd be having this conversation, Julie.
That's a lovely example. And actually, I know in our audience, we've got many students, and you often think that when you're, just starting out in your career, that you don't have many opportunities to show your leadership qualities. But actually what Andrew has just described there is leadership at the point of care. It doesn't matter what level you are in a hierarchy. They saw the need and they acted upon it, didn't they? And liaised with the people that mattered and counted for you. So thank you very much for that. I've realised that we've now, time flies by when you're enjoying yourself. I think we've reached the end of our question and answer session. So I would like to thank all of our speakers for answering those questions, and also for all of you for sending in, very searching questions. Please do send more. We will attempt to answer them, as I say, afterwards. And it might be that you speakers, you might want to just throw some questions to our audience in the chat box as well. So what I want you to do now is, we've had a long chat, haven't we? You've heard all the presentations. I would like you now to think about what you might do differently and put that into the chat box at this point, before we then reach our summary, when I'm handing over to Heidi Wright for the summary. But first, could everybody just put in what they would do differently, maybe one thing, and then Heidi will sum up for us and sort out our peer discussion groups. Okay? So all thoughts into chat box now, please. Thank you. I can see things starting to come into the chat box. I'll just give you a few of these before Heidi picks up for the final bit. There's things about listening more and giving time. That's very important. Definitely about listening. People talking about the golden minutes. What matters most to them. I think that is a very important thing that we can take away from tonight, that what matters most to the patient is very, very important, and that we accept that total adherence may not be the right thing for the patient. So I think you're coming up with lots of really good ideas though, so thank you for all of those. Okay, I think keep them coming in, but I'm going to hand over now to Heidi for our summary and a bit of information about our peer discussion groups.
Okay, thank you very much, Julie. So I will need to echo Julie's thanks to everyone for attending tonight and for your engagement with this event. Really appreciate you taking the time out to join us tonight. A big thank you also to all our speakers, our panelists, our chair. Thank you all for being so open and sharing your stories with us. It's been really thought-provoking. I've picked up a lot listening to you all tonight. And lastly, a big thank you to Rachel, who's been working in the background behind the scenes to prepare and support this event as well. Just